So just wanted to thank everybody for joining, and we will stick to the hour because I know people's time is precious. So we've got some new people who've joined us today, and I just wanted to introduce those. As you know, we've been developing the coalition since last March, and now it's really becoming a sort of what seems to be the need is a hub for radiotherapy, for all things radiotherapy, so that we can extend and help and support people. And so there's been a number of recent international talks around cancer in general and some about radiotherapy, and so we've invited some people today to join us. Certainly, we've extended the invitation to those who joined the Economist Roundtable, talking about the priorities for Europe in cancer. Now, Julie Fitzsimmons is joining us today from ECHO. They've had their recent cancer summit, and I know, Yolande, you're involved in some of those. So, Julie, welcome very much.
Yes. I'm on mute too. Thank you very much.
No, you're very welcome. We look forward to hearing more about ECHO. Also, we've got Gustavo joining us from Raise Contra Cancer. Is that right?
Hi. Yes. Thank you for the invitation.
And I understand you do a lot of education of radiotherapy in low and middle income countries. Is that right?
Exactly. I come actually from Peru. I'm actually based in Germany, but I'm still working on the region. So trying to raise awareness and improve access to radiotherapy.
Great. No, well, welcome. You're very welcome. Also, we've got apologies today from Kerry Adams. He's got some medical issue he's dealing with, but perhaps he's going to join us next week, because I know they've had the UICC recent seminar about strengthening the case for cancer investment. So welcome all today. Just to update you from last time, for those who weren't here, last time we had a really helpful meeting about how radiotherapy has technically changed during the pandemic, particularly in terms of hypofractionation. And we've now produced a white paper that was published today on the website. And Sue will help us with probably an editorial to go forward to the Red Journal about really making the case for, we had to change a lot and the community responded really well, but we really have to get back to evidence-based and quality in radiotherapy and how that can be delivered. So that's useful. In that, we discussed last time about the use of data and radiotherapy data sets. In fact, in England, just yesterday, we published our radiotherapy data sets. Obviously, data from the machines directly counted in terms of numbers of patients, divided into fractionation, palliative, radical, what changed, really useful data. And the discussions we've been having recently with The Economist and others about how radiotherapy is at the forefront of electronic data capture and how that can be really useful for planning services and efforts. So we will have another session on that another time. But getting down to what people felt they needed today, moving on from last time about the hypofractionation, is really about the economics of investing in radiotherapy as part of cancer care budgets. So we wanted to really, at the end of today, talk together about how we can draw up an action plan about how we really can put forward the merits and the investment of radiotherapy in cancer care programs. To also, that will shape awareness and policy and education. So we've delighted our main speaker today is Yolande, who has done all this work in Europe about and the world about the economics and tariffs and this type of issue. So I'll stop talking now. And so Yolande is going to talk to us about the evidence of economics and how that can drive change in global radiotherapy. So hopefully that's put it in context. So Yolande, over to you. Tell us, where are we, where we should be going?
Thank you very much, Pat. Thank you very much for the introduction, and thank you very much for the invitation. And I see a lot of people that I do not know, so nice to learn to know you, and hopefully we will get some fruitful exchanges hereafter. There are also some who know me a bit better and may have seen some of these slides before, so let's just go through the slides and have some discussion thereafter and see how we can get the discussion going. So I just picked on several issues that I've been working on before, and I always like to, and I'm going to, okay. I always like to start with this quote from the United Nations that states that the right to the highest attainable standard of health includes availability, accessibility, acceptability, and quality. And so these are 4 core topics that I think we really should address and really be aware of, that they are closely linked to each other and they should interact with each other. So you can see them here again. And actually, well, if we speak about acceptability, then, well, this can also be translated into efficiency. What is acceptable for a society is typically seen as something which is where a society is willing to pay. So this is very different, also referred to as cost effectiveness. But also more recently, the equation has been looked at in a different way in terms of value-based healthcare. No, I'm not going to really focus on these topics of cost effectiveness and value-based healthcare too much. But you should know that within these 2, of course, core are the costs and the budgets. And many do not like too much, well, as radiation oncology professionals, not too many of us are acquainted with these topics very much. I've always been very interested in costing. And I think that really these are indeed core to understand how the rest can be made accessible. Because from a provider perspective, it's quite important to know the resource cost of what you're doing. From a societal perspective, the equation there is more in what does society pay for a certain treatment, in this case radiotherapy, and this is linked to the reimbursement system. And these 2, and the balance between these 2, well, also impact on what is made accessible and available. Is the treatment available, and is it also accessible to a patient? So these concepts are all closely interacting and related. On top left, you also have the quality, and quality is then, well, more the translation, I would say, of efficacy of new treatment strategies as they have been evaluated through clinical trials, or effectiveness, which is more focusing on real world data. And you already mentioned, Pat, that UK has an enormous, nice data set, which I would like to learn more about. But I think these 2 should really go hand in hand. It's not only enough to have efficacy, we should also have effectiveness data. So in terms of efficacy and how can it impact on clinical outcome of patients? Well, this was an exercise that probably most of you know, and many of several of you that are here today have also collaborated in this. This is the Global Task Force for Radiotherapy on Cancer Control, which was a project that was driven by Mary Gospodarovic 5 years ago, well, published 5 years ago now, where there was a modeling exercise of how could we close the gap to radiotherapy worldwide, and if we could do that, what would it cost, but also what would it bring us? And in terms of efficacy, actually the whole modelization was built on a very broad model that is initially described by the group of CCOR in Australia, where they looked at all the evidence, published evidence, and translated into guidelines for radiotherapy. And so defining for which patients you really need radiotherapy, and what would then be the benefit if you would have optimal access. And well, what was calculated was that in 2012, this could save 580 lives on an annual basis. And by expanding it to 2035, with a higher number of incidents, this may give us the opportunity to save about 1 million lives each year if we would have optimal access to radiotherapy. So for me, that's the summum of having a kind of outcome measure from the clinical efficacy that has been collected over the years. But if we, for the perspective of this presentation, I would like to highlight just one specific topic of clinical efficacy, and I know it links to the hypofractionation that you've been discussing before, and I would just like to pick out breast cancer as an example so that we can build on that in the rest of the presentation. So you probably are, or many of you are aware that in the UK there has been extensive programs in testing hypofractionated radiotherapy for breast cancer. And this is a publication from the START trial that compared actually normal fractionation, so standard fractionation over 5 weeks, all or not with a boost. After that compared to 3 weeks of radiotherapy. And actually, this is the follow-up for 10 years follow-up data that they've been published. And what they saw is that there was no significant difference between 50 gray in 25 fractions and 40 gray in 15 fractions. And this was already published in 2013. So, and this was already 10-year results. And after that, more data came on the hypofractionation. Actually, in 2020, they now have also published the 10-year results of the FAST trial, which compared the 5-week schedule with a once-weekly schedule. And again, there was no significant difference between 50 gray in 25 and 28.5 gray in 5 fractions. And now more recently, there's the data that have been published on 5-year results for the Fast Forward trial that have compared the 3-weekly schedule, which was evidence-based since the START trial, with 5 fractions, but giving it in an even more condensed way in 5 days on a row. So this is actually a very nice example and very huge example of clinical efficacy of hypofractionated radiotherapy. So a type of evidence that I think should immediately become available to patients, but we do know that this is not always the case. We'll come back to that later. In terms of availability, accessibility, cost and cost effectiveness, I would like to give you a few data that we've been collecting over the years with the HERO project. The HERO project is a health economics in radiation oncology project that was formally launched in 2012. It was a project that was initiated on demand of the board of ESTRO, because it was felt that besides all the evidence that we generate as a radiation oncology community in terms of clinical efficacy, technical aspects, and so on, we also need the more health economics related topics, which are broader than just cost effectiveness, but also looking into the broader context of health services research. And so that's how this structure was being developed. I think it's quite important for you to understand already that ESTRO has been focusing on these topics: needs, availability, costing, and well, economic evaluation has not been formally addressed as such yet. But the idea was that as a European society, we would like to support the national societies, so the radiotherapy communities in the different countries, with data that they could use to promote or to support or to leverage radiotherapy and access to innovation in radiotherapy in their countries. So the idea was to provide data that they could use in their own country, because ESTRO as a European society does not interact at governmental basis in each country. So just a few data. So how do we define access? I know Zubi also has a very nice presentations on that, but very typically, very often access is being defined as the available resources for the population. This, of course, well, makes abstraction for the fact that within a population, the cancer incidence may be very different, and that the radiotherapy indications for that reason may also be very different. So we have also looked at the available resources per radiotherapy indications across Europe. And as you can see in the heat maps, this has an impact. It has an impact whether you look just as number of machines, for example, per what it is here, megavoltage unit per million inhabitants, or if you tailor it to the radiotherapy indications. And we are convinced that the latter is the better approach. You should know for how many patients and how many radiotherapy indications you need the equipment, and you should use that as a benchmark. We then also looked in Europe, well, what is the actual utilization, and that is where we compared the optimal utilization that has been defined through the progress or through the models of the CCOR group in Australia that has been translated to Europe, and we compared it to the actual delivery of radiotherapy. And you see again, we have less data here than the availability of equipment, but you see again that the heat maps with optimal uptake to very limited uptake varies very importantly across Europe. So the way you look at access is really impacting on the figures that you get. So this again shows the last picture on the right in the former slide here in a bar graph. And what you see is that if green would be the optimal utilization, tailored for each country. So based on the incidence of cancer, the number of indications, based on the evidence, and you translate that to the number of treatments you should be delivering, then you see, and you compare it to the actual treatments being delivered, then you see that there's still an enormous gap across across almost all countries in Europe between the optimal and the actual use of radiotherapy. So, and what we defined is that about, or at least 1 out of 4 patients do not receive the radiotherapy they need, even in a high resource region as Europe. And actually, we also predicted what would happen if we would expand that based on the demographics. So the patient population becoming more elderly. And we know that that means that the incidence of cancer is also increasing. And you see that on average, we computed that about 16% of radiotherapy courses would be needed on top of what there was predicted in 2015. So over a decade, we would have an increase of about 16%, whereas we already had a gap at that moment. So it has also been shown in different situations that expanding radiotherapy very often just keeps pace of the increasing needs. So we have to take that into account. So what we didn't do at that moment was to really try to have an idea of the number of resources that we should have to really have an optimal coverage. That was done in the Global Task Force. We didn't do it within HERO, but actually we have developed since a cost calculation model, and since it's based on time-driven activity-based costing, and it really calculates the amount of time that you need resources based on the activities that are done within the treatment process, you do not only have the ability to estimate the costs, but you can also estimate the resource needs. So this program has a really dual approach, but I will show you some data on the costs. This is a purely modeling exercise, and I think it's interesting to see, because the title says that fractionation and complexity impacts on the cost. And what you see in this is that you have here breast radiotherapy computed, well, or costed for 3D conformal radiotherapy in standard fractionation, in hypofractionation, which was defined as 15 fractions, and then with IMRT. And typically, indeed, we have always known or claimed that more advanced radiotherapy techniques by definition are more expensive. Now, this is very often the case, and this is indeed definitely the case if it means that you need to do new investments. And it definitely is the case in the earlier phase of implementation, because typically it requires more time, it requires implementation, you have a learning curve. So in that moment of time, typically the newer technologies will be more costly. But this model was populated, so I said again, it's a hypothetical country that we modeled, but the times were estimated on the basis of a group of experts in radiation oncology. And as you can see, is that the cost calculated in this model for IMRT was almost the same. It was slightly higher for IMRT than for 3D. And this was really purely based on the fact that it was estimated that at this point in time, IMRT doesn't really take much more time than 3D conformal radiotherapy, and that therefore the cost is not different. But that's based on the assumptions in the model. For hypofractionation, though, you see that the cost is indeed lower. This is, by contrast, an exercise that we also did with time-driven activity-based costing several years ago already in Belgium, in active radiotherapy departments. And what you see is, well, 2 different ways of allocating the overhead cost between blue and red, so don't focus on that. But you see all the bars, and this is external beam radiotherapy. And you see first the hypofractionated schedules, and then the standard fractionation schedules for breast cancer. And what you see is that in hypofractionation, indeed, and these are real world data that we collected in 10 radiotherapy centers in Belgium, you see that IMRT indeed was more expensive than 3D. And this was also the case in the standard fractionated. And if you went to motion management, so in terms of gating, you see that the cost even increased. So these are real world data. And what you see here, the bars show you the variation in cost amongst the different radiotherapy centers in Belgium. So indeed, You can look at it either way. This is an exercise which was already done 7 years ago. This was a much more recent evaluation based on estimates of experts. And you see that there's some acquaintance about the time we need for IMRT if you look over this time span. If you then put in contrast the reimbursement, and maybe I should go back one slide if I can. So these were the costs that were calculated in real life in Belgium. So you see that the cost hovers somewhere between 3,000 and 4,000, which is actually very limited. But if you then look at the data that we collected across Europe for reimbursement, that the levels of reimbursement paid in the different countries. I must say that these data have been corrected for purchasing power parity in order to make the comparison amongst countries feasible. But what you see in this slide is different countries. And you see the level of reimbursement in the different countries. In red for standard fractionation, in blue for hypofractionation, and in green for accelerated fractionation, so the 5 fraction schedules that I showed you before from the FAST trials. So what you see is, for example, if you look at Belgium, although there's a slight variation because of this correction for purchasing power parity, it is actually almost under reimbursing the real cost of radiotherapy. If you see also across countries, you see an enormous variability. This is all Europe. And you see how the reimbursement levels are extremely variable. And this is in part related to the, well, this has been corrected for the GNI of the GNI of the country. So that doesn't really play. And you see that, for example, countries as Hungary, with a much lower economic welfare, still have a pretty high reimbursement. But then other countries, as for example, my own country, are much lower. Interesting is also that in some countries, there's no distinction made whether you treat radiotherapy breast cancer with standard hypo or accelerated fractionation. You get the same reimbursement. But in other countries, and in the majority of the countries, there's a lower reimbursement for hypofractionation. So from that, you can indeed conclude that in most countries in Europe at this moment, hypofractionation is still disincentivized, which is of course a problem, because that means that there's a hurdle of uptake of hypofractionation if your department is being less reimbursed for delivering that treatment. So we have been thinking within IPEC, which is the Innovative Partnership for Action Against Cancer, which was a European project where we have been discussing how to reimburse radiotherapy most optimally. And it was also looking into complex surgery and the issues of reimbursement. And actually, one of the conclusions, and if some may be interested in seeing the report that I think is now publicly available, I can point you to this report later on. But what was concluded from this report, that probably we should move towards episode-based payments, and not really, well, we already know for quite a while that payment by fraction is not the best way in motivating or in giving the right incentive towards the evolution that we now typically see in radiotherapy. Also, we've been discussing how to use the very changing landscape, or how to approach the very changing landscape in innovation in radiotherapy. And we indeed also concluded that probably having provisional reimbursement for innovation that's still under evaluation would be a right way to go. And actually the data that I showed you for Belgium were done in favor of having a provisional reimbursement schedule for SBRT, which we have done over the years.
Can I ask a question on the previous slide, please?
Yes, of course.
The Belgium cost, is that cost from the hospital perspective?
Yeah,
or is
that's provider cost.
Perspective?
That's provider cost, yeah.
Okay, thank you.
Yeah. This is another slide that I wanted to share with you, because very often, as you probably know, people think that radiotherapy is extremely expensive. It is true that the investment in radiotherapy, the upfront investment, is high, But of course, these high technological equipment is used over a prolonged time, typically 10 years or in certain situations even longer. So it is spread out over an enormous amount of treatments be delivered over that period of time. We should also be aware of the fact that, of course, personnel is, well, radiotherapy is a highly personnel demanding treatment as well, and that salary costs play an important factor in the costs. But apart from the belief that radiotherapy is extremely costly, we always claimed that radiotherapy only costs about 5% of the total cancer care budgets, or only consumes about 5% of the total cancer care budgets. But we never had very good firm data on that. In the survey that we did with HERO on collecting the data in different countries, we had the countries that you see here. I think there are 9 countries, if I'm right. I don't remember exactly. But where we had the possibility to indeed collect data on the budget of radiotherapy and compare it to the budget of cancer care and to the total healthcare expenses in these countries. And as you can see, the claim that we had for many years that radiotherapy only consumes a very minor part of the cancer care budget has been confirmed by this data. And actually, I should also tell you that these data have also included investment costs. So it's not only operational costs, but it's also the investment budgets have also been accounted for. So you see, we found about 7% of the cancer care expenses being allocated to radiotherapy, and less than 0.5% or about 5.5% of the total healthcare expenses typically go to radiotherapy. I'm still not quite sure whether this is good or bad. I mean, it's good to prove that we are a low-cost treatment modality. It may also mean that we are not enough reimbursed. So I think that this is maybe something that we should discuss further. Now, this data have been used by ESTRO in order to build a whole discussion around how do we use this research data in this health services research to go to public affairs? And as you've seen, well, we have developed scientific data. They have been published. All the data that we gathered have been published in journals, very often in the Green Journal. But for example, the reimbursement data made it to the Lancet. We then also defined messages that we wanted to well, first make clear within the ESTRO leadership. We also made advocacy toolkits and flyers that the national societies could use based on the data that we had generated to the HERO project to guide them with their, to take up the discussion within their country. We wrote a white paper on radiotherapy a few years ago. We also spent a lot of time in trying to really go to the EU decision makers and trying to put radiotherapy on the agenda. And there also we use data that were gathered across Europe as a kind of well, incentive for them to understand radiotherapy better. And we even went to policy fora and we participated to EU and international initiatives. So we really built up a whole momentum on the basis of the scientific data that we generated, and we took them at different levels. We also had country level experiences that where we used this data. So it's really trying to close the access gap and trying to also close the knowledge gap. So because we wanted to deliver data and have a knowledge base for health and economic evaluation of radiotherapy that each country could use and see itself benchmarked in the other countries. It strengthens the national societies of radiotherapy in the different countries and the radiotherapy community to use this data and to take up the discussion with the policymakers, and it inspires to advocate for better resource planning. And ultimately, well, of course, we are, well, if we have better access and we can better provide radiotherapy to our patients, we hope that we can close the gap in access and improve outcome. So after the Global Task Force, which was a one-year project, we didn't want to let this project completely, well, die. And it was requested by Mary whether we could put it under the umbrella of ESTRO, and if people who had been collaborating in Global Task Force could join each other there. And the purpose of the GIRO, which was the project that the project name that we defined, which means Global Impact of Radiotherapy in Oncology. The purpose is at the aim to save lives and improve quality of life of the cancer patients through data-driven and evidence-based innovation in radiation oncology. We have the mission to try to reduce inequalities and to ensure universal access to radiotherapy. And we really want to look for affordable, accessible, and meaningful innovations and seek for support in collaboration and partnership. And I think so it's very good that we have this discussion today, because I think we can find a way to collaborate. So I want to repeat to you the calls to action that the Global Task Force has set forward at the end of the Global Task Force. That was call for population-based cancer control plans, including radiotherapy, because we know that radiotherapy is only mentioned in about 40% of the cancer control plans. There was, of course, the claim for expansion of access to radiotherapy. There's an important need for building human resources to expand human resources for radiotherapy. We know that we need several years to train radiation oncology professionals. So, and we also computed in a global task force that there's an enormous amount of people that we need. So this is really extremely important. Then we also put forward that sustainable financing is needed to expand access to radiotherapy, and that radiotherapy should be aligned, or the access to radiotherapy should be aligned to universal healthcare coverage. So you probably have, I know that Mary has already been speaking to you a few months ago, I think, so I suppose you all know the data of the Global Task Force. You know this heat map of the world that shows you radiotherapy coverage, which in certain parts of the world, high-income countries typically is very okay, even in some countries overrepresented. But in vast majority of the countries worldwide, there's an enormous gap in availability or in coverage of radiotherapy. And we know that Africa, by far, in terms of availability, is worst off, with many countries not only having severe under-provision, but even having no radiotherapy whatsoever, as you see from the white spots. And this is work that we did with Zubi and Jake van Dijk after the conclusion of this project, was that we also looked into where is the additional investment that we need per geographical region. Can we really try to have an estimate of the additional investment that should be made? And you see here in terms of regional, and you see that, well, Asia Pacific is by far the one that has the most need for additional investment, and that is obviously related to the fact that it's such a highly densely populated region. Africa, as I showed you on the former map, has the biggest gaps from starting from scratch. But if you look at in the total amount, Asia Pacific is by definition the most demanding in terms of additional investments. And if you then look by geographic, by income region, then you see that even in high income regions, there's still needs. This is very often mostly related, not so much to the equipment, but much more to the training of personnel. This slide you also know from the Global Task Force, where you see that, of course, the amount of money that we would need to close the gap is quite extensive. But if you roll it out over this purple line over the years, over a 20 years period, and you compare it to the human capital benefits over the year, then you see that after 10 years of investment, they start to pay off. But if you would look at the full economic benefits, the full income benefits, then you see that the return on investment comes even much sooner. And we also calculated that if we would be able to optimize the way that we deliver our radiotherapy, and these are the ones that we have been looking into the Global Task Force: quicker planning, swifter quality assurance, shorter time slots, lower investment cost, then you can almost halve the cost of radiotherapy. Of course, if you also, another way of getting your radiotherapy at least in regions where there's still a high demand of radiotherapy, you can make radiotherapy less costly and more efficient by going to hypofractionation. I want to say it in this way because in, for example, my country, with availability of resources that are, well, we are well covered in terms of resources. If we go to hypofractionation, then we will still use the same resources because we will not be able to immediately disinvest in radiotherapy. So the lower cost and more efficiency is really related to the fact that you can treat more patients if you use hypofractionation. So that's why in the Global Task Force, actually what we did recently is doing a survey, because we didn't only want to know, well, in these modelizations of access, and the costing in the Global Task Force, we used the assumption that people would use the optimized treatment schedules. And for breast, this was hypofractionation. For bone metastases, this was single fractions. Where we know that in many regions of the world, in many countries, in many departments, this uptake is still not optimal. So we wanted to get a sense at worldwide level how hypofractionation is being adapted. So how the evidence that is available is shared to the radiotherapy community, and what may potential drivers and barriers to adopt specific treatment strategies and to support the development of new models for radiotherapy delivery. And so we evaluated hypofractionated radiotherapy in 4 clinical scenarios, that is in breast cancer, prostate cancer, cervical cancer, and bone metastases. And within each type of tumor, we had different scenarios. For example, for breast, we looked at breast sparing, post-mastectomy, lymph node positive and lymph node negative. And so for the different tumor types, we had different scenarios. We did a survey that we launched first through ESTRO, but we also collaborated very closely with the IEA in contacting a large group of people being radiation oncologists, not anymore in training, so accredited radiation oncologists. And we had answers of over 2,300 radiation oncologists in 93 countries worldwide. And well, the largest uptake came from Europe, but we had a pretty good spread worldwide. So these are data that are now under revision after first revision for publication in radiotherapy and oncology. So we hope that this data will come out soon. This slide shows you the preference for hypofractionation in the different regions of the world. You see them in different countries here, and you see that the different scenarios are shown here: lumpectomy node negative, lumpectomy node positive, mastectomy node negative and node positive, and then palliative symptom control. What we typically saw in all scenarios that we looked into for palliative radiotherapy is that hypofractionation is the rule all across the whole world, actually. The type of hypofractionation is still variable. This is still under revision. This is just the high level data. If you go in more detail and you see which fractionation schedules are used, then you see still some variability. For example, for bone metastases, 10 times 3 is of course also hypofractionation. Now, if we look for the uptake of hypofractionation across the world, and you see that in Europe and North America, and I should say that North America was quite heavily dominated by Canada, which maybe explains the data a bit, that hypofractionation was had a high uptake or high preference in those who responded, in contrast to Africa, where the uptake was pretty low, where you would, in say, typically expect that due to the very limited resources, there should be an incentive for uptake, but there was not. If you look at in the mastectomy patients, you can see that the highest uptake here, interestingly, was in the Middle East, and the lowest in hypofractionation was in Asia Pacific and Latin America. And similar data you can see for the node positive setting. So you see the variability across regions in the world, and what you can conclude is that it's definitely not specifically so that these regions who have the most needs in radiotherapy in terms of lack of resources will be the ones who adopt the most efficient treatment schedules. we tried then also to evaluate what would be the justifications and the barriers that were perceived by those people who respond. And so if you look at the justifications, we looked at different ones. So the clinical evidence, the economic and resource impact, the professional culture, and the patient considerations. And what you see in terms of justifications, that the evidence available, the equivalent local control and the equivalent toxicity that is available in the literature was really driving the justification for using hypofractionation, as well as patient convenience. What was also seen it was that resource optimization in some countries really played. So using the resources, the machines more efficiently, and having a less expensive treatment strategy was also quite, well, was seen as a justifier for many of the respondents. Reimbursement setting was not. Obviously, very often I showed you reimbursement goes in the opposite direction. So it's not so logical that we don't see it as a justification. If we then turn to the barriers, you see that clinical evidence was seen as a barrier. So there were still quite a lot of people responding that there's not enough long-term data. I showed you in the beginning that I think we have a lot of long-term data. Inferior local control, acute toxicity, late toxicity. So these fears remain in the population of in the community of radiation oncologists. So I think there's really a message here that we should cast. We should bring this message even more across, although the evidence is there. It still is not completely diffusing through the radiotherapy community. Here, we had expected that technology would, by some countries, be a barrier for adopting hypofractionated schedules, so having less advanced technology and more risk of fear of toxicity because of that, but it was not perceived as such by the respondents. And also reimbursement, where I showed you that reimbursement may be a negative incentive towards adopting hypofractionation, was by the respondents not perceived as such. If that plays, we don't know, but they didn't feel it as such. And this is then what we try to do more lately with a young collaborator from Canada, but she has European roots, and she spent a few months with us at Estro to work on data from HERO, and she linked actually the data from Europe that we collected for Europe for GIRO, and she tried to find justifiers or associations between one, data from HERO, so availability of resources and so on, but also other socioeconomic factors that you can just find on the internet. And what she found for breast cancer, and we show you the data for breast cancer here, is that indeed what we saw for breast conserving, the uptake of hypofractionation was strongly associated with having larger radiotherapy departments. So if the respondent was working in a larger radiotherapy department, typically there would be more preference of using hypofractionation. Interestingly also, there was a link to self-perceived health. So in countries where women have a higher value to self-perceived health and then higher self-perceived health, there was apparently, we are still evaluating what this exactly means, but patient factors apparently also seem to play a role. What is, I think, more strong here is a link to hypofractionated specific reimbursement. So as I've shown you in Europe, most of the countries, if they are using hypofractionated specific reimbursement, this typically means that they get less reimbursement. And you see that this has indeed, in this link that we made, had a negative impact on using hypofractionation, especially in those in which the efficacy data are less strong, because the data are most validated for breast conserving node negative or less. Well, the population that was tested so far was less large than in the node negative breast conserving treatment. So if the evidence is less strong or perceived as less strong, then then the reimbursement starts to become a factor, or at least that's what we seem to perceive in this data. So I think this is my last slide. So yeah, what we want to do with GIRO, and I think I really would like to invite you to discuss how we could potentially set up collaboration, is to generate evidence and still generate evidence on the practice and economics. then use that to problem solve for solutions. And of course, the ultimate aim is to improve cancer outcomes and save lives. And we really think that we should do it by a united action of leaders in radiation oncology. So I'm really happy to interact with you on that, if that's what we still have time for. Thank you very much for the invitation.
Yolande, fantastic. That's absolutely great. Sam, could you perhaps bring up the whole screen so we can see each other and not the slides? Would that help? So we can have our discussion?
Yep, I'll do that now.
Great, thanks. Yolande, that is absolutely fantastic. So a lot of data in there. So who would like to kick off? Because as you say, this group here, how can people help in terms of economic solutions and other solutions? I was just wondering, you know, we've talked before in our group about digital solutions and the post-COVID challenges, and whether industry have got some solutions. Who wants to kick off in some thoughts about steps forward to link with Yolande's work? Louis, I was thinking perhaps from the States, what's your thinking there? Because I know you talked to us before about probably reimbursement and evidence-based was a little bit more of a challenge.
Yeah, hi. So thanks. That was a great talk, and I really did appreciate the way that you put it together. You know, I think things there's a lot of similarities in the States. You know, currently we're paid based on what's called fee for service, and so, you know, the more clicks you have, the more you get paid, and so there's a direct correlation between the number of treatments and the reimbursement that you receive. And I think the slide that demonstrated, based on the time-based accounting formulas, that you know, IMRT is, you know, not significantly cost-based more, but clearly in the United States, the incentives are to utilize IMRT specifically because it's reimbursed more, not necessarily because of cost. And I think that that's, you know, a real icebreaker in terms of understanding cost versus expected reimbursement. And I think that plays a role in terms of, you know, how the mindset is. If you look at breast hypofractionation in the States, it has taken a long time for it to catch on. And although I would only say it anecdotally, I would say that the larger centers, like in Europe, you know, are the ones that are advancing hypofractionation more so than the community-based hospitals or rural hospitals. And without having data, again, you know, there's an incentive based on reimbursement there. The issue that we do not necessarily have in the States, unless you get into rural areas, is the access. So, you know, metropolitan New York probably has more Linacs than the continent of Africa. So we don't have to worry about hypofractionation in the context of access. And I do think that raises a particularly interesting opportunity worldwide to create access through hypofractionation. But clearly and similarly in the United States, the overall cost of radiotherapy as a percentage of overall cancer is reported at around 10% or so. So maybe a little bit higher, but still relatively small, and probably lower as we're starting to get into more expensive drugs. And so from a value perspective, I think the argument to be made is, you know, the outcomes associated with radiotherapy as a relative value against the overall spend of, you know, cancer care in general. So it's a provocative, it's a provocative discussion, and it's something that's close to my heart in terms of, you know, the work that we do to try and create value and then figure out how we get paid by value. And, you know, there were just a few countries that I saw on one of the slides and you know, where there was equity based on payment. And I'm sure that was a reflection of a value-based driven approach toward payment that I think is a model that we should probably be thinking about to create a long-lasting access opportunity for radiotherapy.
No, thank you, Louis. That's really helpful. I'm just thinking, sharing other information. Gustavo, you've joined us recently. In terms of your work with South America and other low and middle income countries, because I know the IEA here and Lisa and people, what's your experience in terms of the usefulness of this economic case and the information you've been getting back and giving out?
I think it's crucial. So actually, at the moment, we're working on collecting data from Latin America. There was some data already sent to the IAEA in terms of accessibility and availability of devices in the entire region. And the gap we have seen is really huge. So these economical models, I think, are going to play a fundamental role. I think from the Latin American perspective, there's a lot of inhomogeneity regarding reimbursement and accessibility also. If we say, for example, access to brachytherapy devices, it's really sad. There are a lot of people, and we know profiles of diseases are quite different between Europe, North America, or Latin America. Just to mention an example. Let's say patients who need brachytherapy for cervix cancer don't really get access to these devices, and it's really tragic. I think from the perspective of Rayos contra Cancer, what we have been doing so far, it's granting access to educational tools in order to improve IMRT contouring planning knowledge, and also trying to establish or bridge some gaps between institutions in Latin America with institutions, let's say, sisterhoods, to call them, between other institutions in the United States or Europe. With this, we have got so far, for example, remote planning, trying to leverage a little bit the workload for some overwhelmed facilities. And also, well, besides educational tools for contouring, for example, this is, or at least at the moment, we got this totally zero cost for participants. And I think this is one way to bridge this gap. Another way is, in any case, hyperfractionation. It plays a fundamental role. What Professor Lievens has just shown is that the utilization rate of hyperfractionation in Latin America is really, really low. And let's say the example from Peru, until quite a few years, it was only one institution, or let's say mostly one institution, taking care of around 20 million people from the entire country, and decentralized in Lima, in the capital city of Peru. Now it's a little bit decentralized, but not optimal at the moment. So let's say that around 15 million people are still being covered by 5 Linux and 2 brachytherapy robots. That's it. There are other centers, but the access is not so easy to get. People have to travel over 1 day sometimes to get treatment. And this is the reality of Peru. There are some other countries in Latin America which have not such a good scenario, and their situation is really chaotic at the moment. I think a contribution from the big societies, namely ASTRO or ESTRO, is quite important in terms of establishing statements that could reach the governments to increase investment in this new technologies and implementing centers. Not only let's say, improving the ones already existing, but increasing the number, because only with hyperfractionation in situations so delicate like in Latin America or Africa, let's say, I think it's not going to be enough. We need stronger investment for more technology, more centers, besides personnel and other items.
I know that's really helpful. And I know the last few times we've discussed the role of industry in terms of their new technologies, say remote planning. I know Varian have got a solution now in the cloud where you can buy into planning remotely, so you don't have to get the system and all that type of thing. I'm just wondering also, is there an element, I'm thinking, Yolande, in terms of reaching out to the sort of the non-radiotherapy community? I know Judy's here from ECHO, in the area of where radiotherapy fits with everything else. Have we been too siloed perhaps? Because in some ways, you know, you're worrying about costs, but if it's only 7 or even America, 10% of cancer costs, that's not a lot, is it? What role have we, in terms of as a radiotherapy global community, got in reaching out to have that dialogue that it's good for everybody if perhaps more investment is radiotherapy? Yolande, what do you think than anybody else?
Thank you, Pat, for this question. Yeah, I think indeed we have been preaching too much for the already convinced. So I think we have to go outside of our own community. And I must say that typically I have a lot of these discussions at national level, and I'm always a bit cautious to play the role we against them, because it's very easy to say, well, their drugs are so expensive, and this is probably not really the right angle to take it. What I try to do is, I think that immunotherapy, with all the caveats, I think that we have to bear in mind, not in the least also because their financial impact, and the fact that there's a lot of patients where we don't really know whether they will fare better with immunotherapy. I think there's still a lot to learn. Also, the ways of delivering the drug, as long as the patient is good, is not really going to the most optimal treatment scenario. Maybe many of them could be stopped earlier. But having all these caveats with immunotherapy, I think it also gives us a possibility to join hands with the medical oncology community, because there are data indeed that radiotherapy and immunotherapy may very well enhance each other. And so taking up that angle, I think, and trying to find angles like that, like, for example, I would say hypofractionation in 5 fractions is also a very good example of where you can say, well, if you have to give chemotherapy after the operation and you only have 5 days of irradiation to give, you don't have this 6 or 6.5 or 7 weeks that the patient has to wait before she starts with chemotherapy. So trying to find these angles to put the message across as a strong multidisciplinary discussion, rather than to try to just, well, we have to educate them, but we also have to educate them through the ways that they understand. So I think this is the type of discussions that we have to try to leverage and find these ways of bringing this message across again and again and again. And I hope that at some point, I have the impression that with immunotherapy, we start to reach now also the pharma industry that was completely not interested in radiotherapy before. And now they start to think, well, where's the potential win-win for the patient, and how could we start working together?
Yeah, no, I think that's fantastic, and gosh, we could talk for longer. I'm conscious we've got our time and we haven't brought everybody in. Look, I think we should carry on these discussions obviously next time. I think perhaps in the interim, big thank you for Yolande, that has been so helpful to everybody. And perhaps also now, if we send round to everybody who all these different groups are and sort of create that interaction now. So Yolande, you've done such great academic work. There's all these people on the call now in the coalition here as a hub to sort of help lead it through. So perhaps if we do that, and then when we regroup after in the new year, bring this together on some of the things we've been talking about, perhaps bring ECHO in, UICC, IEA again, about where we can develop this forward. Would that be okay? Because I'm conscious of time. But thanks everybody, and we'll put everybody in touch with everybody.